Welcome to everyone. It's my great pleasure to welcome you all today. But I've been instructed to give very important announcement first. I hope you were enjoying the reception before, but please do stay for after the event because we will have the great company that we have here, but also additional drinks and food. After a great conversation, we hope to continue that in the foyer afterwards. So please stay. And it's great to see so many familiar faces. Many of you were with us last year when we celebrated IFPMA's 50th anniversary with a reflection on what we called the 50 years of global health progress. And our theme then was continuing progress in global health, working together for the future. So what better way, especially at the World Health Assembly this year, to have to gather together and really talk about future global health progress by standing together and committing to accelerating achievement of universal health coverage. So UHC is a daunting task. Let's not kid ourselves. The joint World Bank WHO Global Monitoring Report showed that more than half of the world's population do not receive all of the essential services that they need. So the first ever United Nations high-level meeting on universal health coverage coming up in New York in September is a really important, potentially historical moment in time where governments reaffirm their commitments to achievement of UHC with the support of the global health community. So as most of you know, UHC 2030 is an important multi-stakeholder platform that promotes collaboration on health system strengthening at the global and country levels. And you may have seen the lovely UHC 2030 asks. IFPMA is a proud member of the UHC 2030's private sector constituency, and you may ask why. Well, it's because we believe that UHC is achievable, but only through commitment and collaboration of all stakeholders. So we all agree that partnership, as underscored by the Sustainable Development Goals number 17, is a critical ingredient to enabling progress for all SDGs. And our industry actively participates in a number of well-established public-private partnership towards global health progress, like Gavi, Global Fund, London Declaration on NTDs, and have started new collaborations and initiatives like Access Accelerated for NCDs. But as we concluded in last year's event, we still have to do more, to do better, and we need to do this together. And so I wanted to share a little bit of what I heard last night and through some of the various UHC conversations happening this week, but something that really struck with me in the conversation yesterday about aligning private sector interests with UHC goals. In his remarks, Dr. Pete Solomon had reflected on some of what he was hearing, and he really encouraged us to think about private-public partnerships in a slightly new way, and he phrased this partnership for shared outcomes. I really like that framing, and because it challenges us to be clear on the goals, ensure interests are aligned, and that we move together in the same direction. So with this spirit in mind, tonight we explored the shared responsibility of all stakeholders in making universal health coverage a reality. So we are very honored tonight to have Dr. Githinji Gitahi, Group Chief Executive Officer of AMREF Health Africa and co-chair of the UHC 2030 Steering Committee, to moderate a very distinguished panel of speakers. And so Dr. Gitahi will be joined by Mr. Stefan Geisels, Executive Director of Digestive Colon Cancers Europe, Europa Colon, Dr. Susan Henshaw, Chief Executive Officer of the City Cancer Challenge, Dr. Emmanuel Ankara Odame, Director Policy Planning and Monitoring Evaluation of the Ministry of Health in Ghana, Ms. Nelly Wakaba, Country Engagement and Support Director for Financing Alliance for Health. So before we begin the panel discussion, I'd like to invite Dr. Gitahi to provide a few opening remarks to frame this discussion. So, Dr. Gitahi.
Good evening, everybody. Good evening. This is going to be a fun evening. So if you are feeling a little tired, this is the place where we cheer you up. Okay? This is where we cheer you up. This subject has been beaten to death. Beaten to death. Okay? And this is a subject on private sector. Is it good? Is it bad? Should it be in UHC? Should it not be in UHC? And all these conversations. Beaten literally to death. And yet, I don't think there is anyone here who has not got health services from a private sector provider, or taking a private sector product, or consider a private sector doctor or nurse. If you haven't, please raise up your hand. There's another session for you elsewhere. Okay, fine. I wish to recognize Princess Dina, who is here with us, and at some point we'll ask her to make some remarks. But what I would like to do is to very quickly just kind of frame this. This is a big year for us. This is the year for universal health coverage. And last year we had the first UN UHC Day on 12th of December, and followed very closely by this year when we have the high-level meeting, UN high-level meeting on UHC. So the momentum is picking up. And as I said, and I said yesterday in the event which was very aptly named, Profiting from Profit, we said that actually for private sector, if UHC is not achieved, then there will be no platform for engaging with government. So UHC is a chance for us to engage with government because it provides for everyone, everywhere, providing financial protection. And therefore, affordability will be a much easier issue to deal with. So yesterday after the event, I actually went and tweeted, and this is what I tweeted. And if you want to see that, my Twitter handle is @Daktari1. @Daktari1. Is it there already? Yes, there. That last one is a 1, not an L. Numeric 1. And I said, private versus public is an unhelpful discussion. There is one health system with different players, different roles, and I wanted to add different interests, but the characters on Twitter could not allow me to add that, so I removed it. That needs a publicly led, responsive, regulatory, and legal framework that governs towards equitable access to health with financial protection. So that's what I tweeted. I had 30 retweets, 54 likes, and 5 comments. And the mix in the comments just tells you that private sector is as loved as it's hated. So I don't know how many are here from just private sector. If you're private sector, just raise up your hand. Civil society, let's see. That's a good balance. Government? I see. Okay. So at least if there was a tug of war, or there was, then at least the private sector and civil society would kind of balance out, and the government would be the referee, as it should be. You're not enough to tug the war. Now, what I saw in the sentiments is, one, people are saying to me, government needs to take the lead. So that was one of the themes that was coming up on the Twitter engagement. The next thing was that civil society needs to be engaged to demand accountability. That also came up. Where are the people? The people need to demand their government to demand accountability, because as I keep saying, governments report to the people. Surprise, surprise. Then the other theme was that there has to be public-private separation. Somebody was very strong that there has to be public-private separation. Somebody also said, health is a human right, and private sector takes advantage and excludes millions of people. This person even added data, said you exclude 100 million people. I don't know where that came from. There was no reference attached. They say private sector excludes millions of people from this human right. Somebody said we need to invest in strengthening the state health system. So there are all these sentiments, and we kind of divided, yet all these people commenting here use either public or private or both at any one time. Actually, I would say both. I meet doctors, I said yesterday, who tells me, this private sector is, terrible. We can't allow private sector to come in. But each of them runs a private clinic and charges patients. So there's a bit of conflict everywhere. So who is the private sector, and why are they loved and hated in such equal measure? When you look at private sector, we have different players. We have private sector international. We have private sector local. We have private sector formal. We have private sector informal. The nurse who runs a clinic near my village could be informal private sector. Some of them may not even have licenses. And it's traditional healers, private sector in the health provision. There is private sector for profit. There is private sector not for profit. So it's not a homogeneous group that we are talking about. So it's kind of spread out all over the place. So in UHC 2030, we looked at how do we bring multi-stakeholders together to converse about these issues? Not only this issue of private sector and UHC, but also about civil society and people participation, about governments and their role, governments who donate money and governments who use the donated money. All these players come into play, including academia, to inform the evidence. And we had a long debate about how to present private sector in that conversation. Some people felt strongly private sector should not be allowed to come to UHC 2030. And some people felt if you exclude the private sector, you're excluding more than 50% of the health sector. There was all that. So finally we settled and said, fine, let's have private sector, but because there's still, we don't trust you enough, so you allow some representation. We wouldn't allow you on the steering committee, but we allow to be represented in the steering committee. I'm being frank here. We are going to allow you to be represented in the steering committee, but on a neutral basis, because we are not sure whether to bring in pharma, to bring in digital, to bring in providers. So we said World Economic Forum is going to present you. And I think you talked about the private sector constituencies. So since then, we have some stability, we have private sector, we have all the constituencies, and we all sit together to make sure that this happens. So over the last 6 months or so, we've been consulting widely with private sector, civil society, academia, and others to say, so what do we want to see as we go towards the Universal Health Coverage High-Level meeting in September? What is it we want to say? And we came up with 6 asks. 6 asks that you can check on our website. But basically, if you're just to look at those 6 asks, they're very straightforward, is number 1, that we need to ask for political leadership beyond health, that it is a social contract with the people. Number 2, we said that we want to leave no one behind. And this is where the conversation around equity and whether private sector can provide equitable services comes in, leaving no one behind. The third issue we talked about is we need to legislate, we need to regulate. So that, as people have told me on Twitter, it's not a free market. Free market for health always fails. Do we create regulation and legislation? We then talked about the need to build quality health services that people trust. After that, we said we need more money in the health sector and better spend. More money, better spending. And finally, we said we need to move together, meaning all these stakeholders need to work together. And we said these 6 asks then have to be kind of within a medium of gender equity and women and girls' rights, cutting across all the 6. So this is where we are. So let's not kid ourselves. There's a problem. So many of the meetings I've attended in private sector tend to be, we can bring in this, we can bring in that. I don't want this to be that meeting. I want this meeting to kind of take some time, and I thank IFPMA for gathering us together to dig deeper in a more honest way and say, these are the problems. Because if we don't talk about the problems, then we don't know how to resolve them. So I'm going to call the panelists up here, but I want you to consider this as a round table, not as a panel discussion. Let's look at it as a round table so that we are all together. The panelists will lead the discussion, but we are all part of this conversation. So I'm going to be getting back and forth, asking for comments and questions, and I hope we have enough time to have that debate. So get ready to comment, to ask. I've also told the panelists to throw away all the notes they had prepared, okay? So that we have a conversation, all right? So let me ask the panelists to come up. So we have Mr. Stefan. I will not try to say your second name, just like I'm sure you'll not try to say mine. Stefan is the Executive Director, Digestive Cancers Europe and Europa colon. His Twitter handle is at Stefan, Gilsses. You see it there. I would like to also call up Dr. Emmanuel Ankra Odame from Ghana. He is the Director, Policy Planning, Monitoring and Evaluation. I am also going to call up Dr. Susan Henschel, who is the Chief Executive Officer, City Cancer Challenge, and then Nelly Wakaba, who is the Country Engagement and Support Director. Sorry, what do you do? You'll tell us, yeah? Okay, fine. Financing Alliance for Health. She's my friend, so I can ask her that question. Okay. Aha. We've started the musical chairs already. So we are going to have a conversation around this. We know there's a problem. Because if there wasn't a problem, we wouldn't have beaten this issue to death like we have done. It would have been resolved. I mean, I have not seen multiple meetings about what is the role of civil society for UHC. I've not attended a single one, but I've attended many meetings on private sector. So I want to go to Odame first, my friend Odame. I have worked closely with the public sector. I've worked with and I've had stories about how public sector and private sector engage. We've had stories where, organization, private sector, because the reality is that we have interests. And yesterday somebody said we have conflicts of interest. We have interests. So when private sector goes to the government and wants the ministry to sign an MOU or one or the other, it's always because there's a product they're selling. There's a product they want to move. They want access to the market. That's the reality. Sitting in the Ministry of Health in Ghana, have you had these engagements with private sector? Have they walked in through the door? What did you like and what didn't you like? And what did you do about it?
Thank you so much, my good friend Githinji. I think, first of all, let me say that I think we're having a great conversation. And like I told some of the audience before we came to sit in here, that I hope that, like was said by John McGlobe, that the age of intellectualism, a lot of conversation, but leads to very little action. I hope we're able to have a conversation that will lead to constructive steps that can lead also into constructive actions. This is very critical. As I sit in the ministry, I've clearly come hand in hand with private sector players, like you're rightly saying. And like as I said yesterday, we set up ministries at a point where most of the world landscape was more public sector provision. And with time, the whole system of redesign and rethinking didn't really take place. So really, the interest even between private sector interest and public sector interest really don't align. And I think that's the challenge that we've had most often with private sector players. Because most ministries of health have clear-cut public sector players who have never really worked in private sector or vice versa. So really, they don't even really understand themselves. And that's why yesterday I said rightly that the term public sector entrepreneur might not necessarily be an oxymoron. Why am I saying it? Because we really might have to look at revolving doors where public sector players can work in private sector for some intervals, come back, private sector players work in public sector intervals, some intervals. Why am I saying this? Because one of the basic things I've encountered sitting where I sit is the fact that sometimes there's even lack of trust between the two players. We've seen a lot of public-private partnerships that don't see the light of day. They go around 8 years, 7 years, and we've still not been able to conclude a deal. Just because of inadequacy and proper understanding, proper alignment, and even the capacity to even engage the private sector, as it were, and also the capacity of the private sector to better understand the public sector players. So there's all this big raft of governance issues, current redesigning issues we have, and until we really look at the design of our ministries of health, as it were, I think this conversation might continue for a very long time. We may have very nice rhetoric, nice architecture, but if we don't get the building right, get the right players on board, it might be a nice building. Thank you.
So there is the issue of capacity.
Yeah.
And you say that many people who work in the public sector have never worked in private sector. And that's a major barrier. Susan, I'll give you an experience that I've had. In some country, you can call it Wakanda. for purposes of...
I'm already scared, by the way.
No, you don't need to be scared. For purposes of not discriminating against any country. So in this country called Wakanda, there was, a pharmaceutical company went in, and you know, let's face it, the pharmacy, especially the major issue is actually with pharma. That's really where the major issue is. Let's also call a spade a spade. That's where the major issue is, because the little shops and little pharmacies and little nursing homes don't have a big problem with Odame and the Minister of Health. It's pharma. So let's discuss where the issue is. So, and pharma has a lot of money and has a lot of experience and is able to engage. And when we come here to Geneva or to New York, a lot of the meetings, the bilateral meetings I see, are between ministers of health and pharma CEOs. Is that true? Yeah, I don't know. I'm not going to ask Thomas Quenny how many ministers he's met since he came to Geneva. But in these conversations, one particular pharma organization managed to convince the minister that actually they were giving a good deal. And they were giving a good deal for cancer medication. And they're like, this drug costs $2,000 a dose, but we are going to give you a discount of up to $1,000, from $2,000 to $1,000. And that sounded like such a good deal to the minister. And, you know, and maybe as he says, capacity to engage, like, this is a really good deal. So they actually signed. And what that deal did was that it took about 50% of the cancer department budget in that country to this particular drug. If you are the ones, you know, you are in this cancer platform, so what would you advise the minister to have done, for example? What should the minister have done in that situation? And what should the pharma company have done?
Okay. Thank you for the easy first question, Gitani. So I'm going to start with what the minister should have done. And I don't know whether there are any ministers in the audience today. Please don't shoot me later. But I think that City Cancer Challenge really encourages all the stakeholders to come together and listen to actually what's required on the ground. And the only way to really do that is to get the data. So if people come together, like they do in the cities we work with, and they actually assess what is the burden, what is the most common cancer, what is the best guideline for treating that cancer, and that's informed both by a cancer registry, so you know the burden of disease, you know the outcomes, and you're collecting information about what pathways are available and what pathways can be created in that country, then you're creating a data ecosystem that the minister can then plug into and understand what he really needs. Because often the procurement of a drug may not be based on actually what's required and actually what patients are being seen on a day-to-day basis in a clinic, in a hospital, in a tertiary centre. And honestly, it's understanding the data. It's understanding exactly what's happening on the ground that will help inform that minister make the right decision.
I'm going to ask you who disagrees with Susan, but not now. I first want to get back to you and ask, you know, because you're working with this very specific kind of platform, where does that data come from and whose role is it to create the data that is required for that decision making? Because right now in many of the countries you're working with, even the cancer registries are incomplete. They're not there. And maybe that goes back to the capacity that, he talked about. So Stefan, from your point of view, because you're in this area, where should that data come from? For us to say, we really want to engage with the public sector, but this data is important for decision making. Do we wait for them to put the data in place? Is there a role for the private sector to assist with this framework? I would like to hear your comments on that.
As a patient, I can say that we look at the problem through the patient journey. So we look at it from the very beginning on interaction with the primary care, the diagnostic, surgery, chemotherapy, follow-up, back-to-work strategies or end-of-life strategies. So there's a lot of elements, little stations on a long railroad track. In every step of the track, you need data. And the only way to get the data is to involve all the different partners. Because you have to understand what is the time between the first symptoms and the actual diagnosis. I think it's very important to understand that and what you can do to shorten that period. there's a time between the diagnosis and the beginning of the treatment, and which treatment is being given, and what's the background of the person, and etc. So there's a lot of data that you can collect both at a social level and at a medical level. Then comes the surgery. What's the time frame of the surgery? What type of surgery is being done? I mean, I have had the extreme privilege to be treated in a hospital where 85% of cancer patients survive. In Belgium. A hospital 20 kilometers away, also a university hospital, for the same condition, 60% of patients survive. And then you have hospitals that don't have even data because they don't have enough patients to have statistics. So the question is, you need this data to be able to assess afterwards, what is this hospital that has 85% survival doing that the other one is not doing? And obviously, if you ask the question to the hospitals, they will say, well, we don't disclose these data. They will, put up their defenses and say, we become vulnerable if we share data. And it's the same with the insurers, it's the same with the pharmaceutical companies, it's the same with the governments. Because the more transparent you are on data, the more you will have a public debate, and that's what people want to avoid because it attacks their power structures. And that is why very often the debate is so very emotional, because the data are lacking. So because you don't have any possibility for a rational discussion, it becomes an ethical, moral, emotional discussion. And I think data for us is the #1 solution to say, that's how it works, that money is well invested, that's where patient benefits and outcomes are generated. And it helps you to look at health systems in a more holistic and systematic way. And we as patients want to be part of that because we have the experience. We know what's happening. We can show how the pathway can be shortened, be made more compact, which health outcomes are more relevant than others. So yes, every single part, including the insurers, because they sit on the data. They know exactly who is insured and who is being treated and reimbursed for what. They have to disclose the data. And it's only by having all this data available publicly that a debate can be had among the different stakeholders.
I think this is a really important issue of data, visibility, privacy. Is there anyone in this audience who has more information on the data? Because you've raised an issue. Data is really important for decision making. Talked about how it comes. You talk about capacity, which they're all related to. Anyone who wants to comment further on this issue of data? Yes, please, and say your name, where you come from, and then you contribute. Is there a mic, please? The people with the mics have been on their toes. This is an unusual panel, so. Yes, please.
Hello, everybody. So this is from City Cancer Challenge.
Yeah.
So I want to comment on data because City Cancer Challenge is based on data. So we collect around 1,100 data points per city on everything around cancer care services, management of the services, quality of the services, and access. I want to say that data for us is critical, but it's very important on who owns the data and who collects the data. Because the stakeholders that make the decision need to feel that they give credibility to that data, that is their data, because if not, they're not going to use the data. And in order for them, because if they need to make decisions based on that data, they need to give credit to that data. And sometimes there's a lot of data that other people collect that maybe is very valid, but because it hasn't been owned by the local stakeholders, they just put it in a box. So I think I just want to make the comment that data has to be locally owned, locally recruited, and validated by all the different stakeholders. They all need to accept that data are valid. And our role in City Cancer Challenge is to make sure that all the stakeholders understand the value of that data, and they have that motivational driver of why they need to collect data and what they're going to use that data for and how they're going to benefit of that data, because if not, it's really hard to collect data.
Anyone wants to comment on cancer registries? And in many of the countries we are working, there's very little data in the cancer registries. So anyone who wants to comment on that, please let me know as you go along. But thank you very much for that contribution. So, Nelly. Yes. First, I saw your titles. You'll need to explain to this audience what the title is rather long. So you can tell us a little more about what you do with Financing for Health Alliance. But I want to come to the financing issue. When you look at the documents that we discussed in Addis Ababa in 2015, and for us to move post-MDG to SDGs, the role of private sector in the development financing was very highly positioned. And even when we talk about private sector in the countries, the understanding is that private sector is going to crowd in money into achievement of UHC. Okay? Is this really true, and where is the money going to come from? Because we see private sector wants the government to buy their products. So private sector brings innovation, but somebody has to pay for it. So where this money that we have, which is actually trillions of dollars to fill the gap that private sector could bring into the sector, from Financing Alliance for Health point of view, is that possible, and where is the money going to come from? Because it's not philanthropy. Yes. We haven't discussed philanthropy. It is within the strategic intent. Where will the money come from?
Thank you, Dr. Githinji. First, to explain my so-called many titles, it simply means that I work closely with the governments that the Financing Alliance for Health serves. For now, we are in 9 African countries, and what we do, we help the governments figure out the costs of their community health systems and their primary health systems by costing their strategies. We know that governments work through strategies, and therefore, if you want investment to flow, you need to understand the costs, right? And not only understand the costs, because like you said, the drug was 1,000 vis-a-vis 2,000. It's beyond the face value, but what's the return on investment, right? There is a step beyond the cost. So we support governments to understand the cost of their community health worker programs, develop their ROI, their return on investment. This is looking at the diseases that they will avert, the insurance, the employment they will create for the women, the community health workers. And then over and beyond that, we help them build an investment case. Because the Ministry of Health language and the Ministry of Finance language is very different, isn't it? We in healthcare understand what it means to reduce malaria by 10%. But my Ministry of Finance people, that they do not understand that. And therefore, we help governments to package this advocacy material in a language that the Ministry of Finance will understand, and therefore we trigger domestic resources as well as donor resources. So basically that's what the Financing Alliance for Health does. But over and beyond that, we also look at other innovative financing mechanisms, the social impact bonds, the DIBs. We help the governments structure that. Coming back to the question, Dr. Githinji, private sector, I do believe that we just need to change how we look at this money we are calling from private sector, because I do believe it's a critical and important sector. And I will not even put it as a blanket private sector. I will actually say pharma specifically. Because when we are talking universal health coverage, then we need these medicines, we need these diagnostics, and we cannot wish pharma away. So just to make the road clear. But then that said, how then does pharma engage government, who are the driver's seat of universal health coverage? How does this money flow without the tag of suspicion? I have happened to work for pharma for a couple of years, Novo Nordisk, and I did engage governments in actually a private-public partnership. But what made this very successful till today is that the way we packaged our approach to government, we did not only come with this tag that there is this product called insulin, but we looked at a whole change. It's a whole chain, you know? So that removes the suspicion from the government that you just want to position your product with us and you make the money. So that's very critical. It's about shared value, if I may reiterate what you said. So the money that is in private sector, it is possible that it can flow to finance universal health coverage. But then the issue is how we package that. It has to be shared value. It has to go beyond the cost. Of course, they have a financial bottom line to meet. But at the same time, we have a social and an environmental bottom line as well as private sector. Therefore, yes, money can flow from the private sector, pharma specifically, or private sector in general. But the thing is, how do we structure that? And government has to always give the vision and take the lead in that, right? And it has to be about shared value. So if I might just give a bit of detail on the Changing Diabetes in Children program that, you know, started back in 2009. When a child in Africa used to die, they could not reach 1 year because of type 1 diabetes. Why? Because it mimics other diseases, and therefore the diagnosis for DKA was always missed. But what did Novo Nordisk do? They came in with not only the insulin as a product to the governments, but they came in with a whole chain to support governments to create the change they wanted to see. So one, they did not create a parallel system. And that's what private sector needs to understand. We cannot, if we create parallel systems, we will not win. We need to strengthen the existing government systems. And then the other thing is look at the whole value chain. So there was training, there was infrastructure development, then there was the product, the insulin, and then there was the supply chain. So if we do that, then we can get money from private sector, not only on the product or the diagnostic tool, but more value beyond the product. Thank you.
Does anyone want to add to this topic? Where does the money come from for pharma? And thank you very much, Nelly, for explaining that in detail. And I was asking you to explain because I wanted people to understand what Financing Alliance for Health does. Yes, Rob. I want to understand this money because it's in arithmetic, I was taught that you have plus, you have minus, you have multiplication, you have division. So is the pharma money that the governments are waiting for, not pharma, private sector, is it additional? Is it a plus? Or is it a minus? Because they have to pay for the products.
I can see exactly where you're coming from, Githinji. I'm Rob Yates from the Chatham House in London. I think what we're learning about this tricky issue of financing for universal health coverage, and it's very important to see where the source of the financing is. Where does the bulk of the money come from that pays the services, pays the health workers, pays for the medicines? And this has been a controversial topic over the years, but it is now absolutely crystal clear that the source of the financing should be public financing. It's the only way to reach universal health coverage. And that's quite simply because universal health coverage is all about everybody getting the health services they need with financial protection. If you have a privately financed health system, you don't get the cross-subsidies. You need the healthy, wealthy to cross-subsidise the sick and the poor. And that can only be achieved through a predominantly publicly financed health system. Now, that's not to say that there might be some people may be buying some medicines over the counter in the supermarket, and there's sort of maybe also some private insurance for the well-off who want to have those types of services. But if you look at the transition to UHC, when we look at when the transition was made in the United Kingdom in 1948, in Korea in 1977, in Thailand in 2001, the thing that almost defines the transition is to a socialised health financing system where the healthy, wealthy are forced to cross-subsidise the sick and the poor. Now, that big pot of money might then actually buy services in the private sector, and of course it will buy medicines from private pharma, but the source of the financing has to be the public sector.
Okay. That is a view that all financing needs to come from significantly, predominantly. Does anyone have a different view? Yes. Please give a mic here.
My name is Moka, and I'm doing work for Oxfam.
Stefan.
Just to add to what Robbie said, is that at the Global Fund, since 2002, with very committed people from the private sector, really committed, really good people, trying to fundraise from the private sector to the Global Fund. The last time I looked at the funding of the Global Fund, the public contribution was 96%, the private contribution was 4%. That was product led, even with Gates, which is a foundation. I don't know if that's a private sector or not, but anyway, it was just 4%.
Yeah.
So it actually says that what you're saying, I'm giving the evidence to what you're saying, that we have the experience of that the funding has to be from the public, mainly, that you can do certain things. We're not saying private sector can't do anything. You can do certain things, but you can't do, can you do it to a scale that every single person who has diabetes will get the diagnosis and treatment because of one company? No. One company out of the three who monopolize the insulin market globally. So, you know, we have to be really careful of what we're talking about here.
I love the debate. Anyone else to contribute? No. Yes, sir? Yes, Stefan, please.
No, I fully agree. I think we, in the countries where I come from or represent in Europe, universal health coverage works because it's funded by taxpayers' money. And there's a system of solidarity. My entire treatment in my individual case cost 70,000 euro. I didn't pay a euro of it. So everything is paid by the government through a tax system. And how does that work? Because it gives the freedom of choice for the patients to know where to go, to which hospital, which treatment or not to take. But also it gives freedom of therapeutic choice to the doctors, because they are not limited by the amount of money that the patient can spend on which treatment he or she gets. I mean, one of the biggest problems that we see in Europe is where private insurance companies intervene because they get discounts in certain hospitals. And so instead of channeling patients and leaving them the choice to go to the best hospitals, they go to the hospitals where the insurers have a discount. And so that's not necessarily the best hospital. So the places where the system works the best and where you have the best overall survival are the ones that are entirely public, sufficiently funded, but with the possibility for all the different providers of services, whether they're doctors, hospitals, surgery equipment, or pharmaceutical companies, they're all providers. And today, these are the guys who are defining the game instead of having a public debate with a representation of the taxpayers who pay the money and the patients. So I think it's very important that, you know, that's how the system should be organized, in my opinion.
Good. So, yeah. So let me then come to this other question. I worked in pharma, by the way, for a long time. I worked with GlaxoSmithKline for many years. So let me ask a question which actually gives medical reps palpitations, okay? Is a question about generics versus branded products, which is all about back into the purchasing behavior of government. And I'm going to come to you, so prepare yourself. But the question is this: if you look at the African economy is about 1% of the global economy. So let's talk about Africa, because a lot of the organizations here are also trying, and that's where we have this problem of coverage. So it's about 1% of the global economy. If Africa was to grow by 5% every year, and the global economy was to grow by 3% only, it would take Africa 70 years to contribute only 10% of the global economy. Not catch up, to become even 10%. So if you look at that economy, and then you look at population growth, and you do very basic arithmetic, and you look at the African economy and you say it's highly informal, and you look at tax efficiency. So you say, we want Africa to achieve the same tax efficiency as OECD, for example, just for argument's sake. And we want, after achieving the tax efficiency of OECD, we can assume it's 30% on average, we also want Africa to allocate 15% of the money to health, which is the Abuja Declaration. When you do that calculation, then you divide that by the population, you still end up with $40 per capita. Yes. 40. 40. When you do the same calculation for Netherlands and country in OECD, you end up with $4,000. So let's then come to the real conversation. If private sector is going to engage with African countries for UHC while still retaining a viable business model, are we going to afford branded products? And how do we take the cut between branded versus generic? And what is Ghana doing?
Yeah, interesting dynamics. But I think you are right, because to start from the point where you ended from, even Abuja Declaration that we set up, this 15%. Most African countries are doing under 10% on average. So clearly, you could see that financing towards health, even by the public sector, is quite minimal. But even an analysis we did in Ghana clearly showed that even development partner funding is quite a drop in the ocean. Look at the comprehensive government funding, vis-a-vis infrastructure, compensation, and assets, as it were, broadly. So I think you are right. But Ghana, we've started a couple of reforms. One of the key things we've done is what we call the framework contracting. So with the framework contracting, we've put about 45 essential medicines on the framework contracting list, where we're able to go through this period for about 2 years, sign with the contractors for 2 years. They are ensured of steady supply, so as to ensure the economies of scale, to be able to have some conversation around stable prices. Then we've also started what we call the LMIs, the Logistic Management Information System, which is going to go live first week of June. Clearly, with the Logistic Management Information System, so we know very clearly what we are talking about here, in terms of the quantities and how much is there in this region, that region, all on a clear IT platform that everybody can monitor. Because for a very long time, procurements was clearly not being done even on consumption data. Procurements were being done on, let's do this, then we have all these expired products. And I always used to argue that, look, these illiterate women who have not even been to school, when they are preparing soup, they know the amount of pepper they need and the amount of tomatoes. And after all this education, we do procurement not based on clear-cut consumption data from all levels coming across, which was a big indictment on the system. So this LMI is going to be put in place. Then the last mile distribution is also where we started. Last mile, how do we get medicines to that last island in Ghana? We have over 40 islands, small islands with over. But you go to each of these islands and you see Coca-Cola being drunk in those islands. So in the same way Coke is able to get to all these islands and riverain communities, paracetamol should be able to get there. How do they get it there? So and that's where we can also learn from private sector and learn a bit from their techniques, how we're able to dovetail it. Then the fourth reform around that raft of supply chain is then the warehousing strategy, the warehousing and distribution strategy. We focus on central medical stores, regional medical stores, and the outlets where we are supposed to get this thing to go. So for now, like you really said, one of the big things we've done is a bit of the generics, coming through the framework contracting. But definitely there are some medicines that we don't have generics, so we also focus on that aspect. Ghana at the same time also has done a major move in terms of health financing. When in 2003 we set up our national health insurance scheme, purely government financed through the taxes. So through our value-added tax, we put in a percentage on value-added, that was 2.5%, and a levy on also the social security to by and large finance the health insurance scheme. And that was rightly stated here. It was to a large percentage public financing. Because we realized that even the amount of money that came in through the premiums was very little, less than 5% of the finance of it. And this health insurance money then goes into purchasing some of these medicines directly and paying for them, because also we have a service tariff for medicines and service tariff for the service delivered itself. So we need a bit of the reforms helping out with a bit of this. But to a large extent, we concentrate on the generic medicines for now. Okay. Yeah, unless in circumstances where there are no generics and there are some branded medicines in certain circumstances that we also purchase.
Anyone who would like to comment on this issue, please prepare yourself. I'll come back to you in a minute. I'll come to you direct. But I want to hear from Stefan. You talked about the fact that you have cover, you have universal health coverage, so you have cover, so you don't have to worry. Is your cover defined in terms of the type of medicines you access, whether they're branded or generic, or is it open?
No, typically branded are protected after launch, after approval for 10 years with market exclusivity. But everybody gets access. So if it's part of universal health coverage and a new drug comes on the market in cancer, it's 100,000 euro, 200,000 euro, 400,000 now sometimes. As a patient, you pay nothing because the entire price of the drug is reimbursed by the healthcare system. How does that work? It works in a way that is, at the moment, I think, relatively sustainable. So we see a right influx of new treatments. So in the last 20 years, we have had cancer drugs for 175 new indications. So it's increasing every year. So there's a big trend of more drugs coming to the market. But the overall bill of what we spend on cancer drugs is still only 40 euro per capita per year.
Okay.
So you have these peaks of these very expensive drugs that for a small segment of the population, but because it's health coverage paid by everybody, the individual patient doesn't have to pay, and the cost is carried by the entire taxpayers community, so to speak. So it's spread over everybody. And I think that's the way it should work. And that allows governments to have investment in these new innovative drugs. After a while, they go off patent, of course, and then they become cheap. I mean, the treatment I received was 20 times the cost of the standard of care 10 years ago. When I received it a few years ago, it was considered the most cost-effective treatment. So it goes from very high to very low, and then afterwards, it's forever relatively cheap. And I think these are models that have to be looked at, also in providing access outside of Europe in more resource-limited settings. And I think, I mean, my opinion is there that the drug should be available as almost at an off-patent price, as at a generic price, but I think still needs a kind of a commercial market to make it attractive for companies to invest, because I think that is really important. Otherwise, nobody goes there, and you're at the mercy of guys who just want to also copy the new drugs. Yeah.
Good. Thank you. Thank you very much, Stefan. Yes, you have the mic? Yes, and then we have a comment here, we have a comment there, and we have a comment there. Yes.
Good evening. My name is Bernd Stoll. I'm a medical doctor of the University of Geneva Global Health, and in this startup called Glosia for the deployment of appropriate medical devices in Africa. And we have an agreement with Novartis Social Business to implement new strategy in the sense of your question. Is there somebody from Novartis Basel here?
Novartis?
You are here. Okay.
Yes.
So I wanted just to say that they decided recently for a new strategy, access to medicine, was presented in the last December at their symposium. And that's a very interesting way to say, of course, there are programs where you open for generics, cheap generics, $1 1 month, okay, you can discuss, and Chinese producers can do the same. But they say this is not enough, because for some diseases, like Chagas disease, heart failure, the Entresto is still relatively expensive, but the patients will not have the money for that. So they create, even if it's still a patent on it, another brand, but from themselves, to give and to create programs in South America to give access for the patients suffering from heart failure by Chagas to have a treatment. And they bought recently a new substance, a monoclonal antibody, which has the capacity to avoid the crisis in sickle cell disease patients. And they say this was a startup creating that. So very nice. The risk is some good publications and then back onto the table, because there is no market. They would never be able to produce in a large scale. So they bought the thing and said, okay, we have some 100,000 patients in America and Europe from sickle cell disease. They could pay, but already in America, most of the sickle cell disease, the patients are poor. But of course, 90% of sickle cell patients living in tropical Africa with no access, and they say we will now, they work for the finalizing to put it on the market, and they say we won't wait 5, 6, 7 years to have the generic. We will 6 months later to start our second brand. sometimes in tropical Africa to help these patients. And I think that's an interesting access strategy of a big pharma, which is just going on. They have a long tradition with leprosy as well. Only that there are no new drugs, there are generics as well.
Thank you.
And if you give just another comment, don't forget all religious, confessional, private health support in the world. There are not only private for money, for profit, there are a lot of private, non-profit health organizations. We have here in Geneva the Aga Khan Foundation. They have some kind of 150 hospitals for vulnerable patients in their area, and all the missionary hospitals in Africa, they contribute in a very significant way to universal health coverage. And
correct.
Don't forget that in the discussion. These are good partners, efficient with perform existing.
Mission Hospital. So there's one here, please. Oh yeah, you want to comment and then bring. Yes.
So while I wasn't expecting
you are highlighted, yes.
commercial,
yes. You'll pay at the end.
Well,
yes.
Yes. I recently joined the company, and it was because of Novartis's access strategy that really brought me to come. What I just wanted to say is what we do is really encourage partnership. We cannot do this alone, and while we are trying to address diseases such as sickle cell and Chagas, we do this in partnership with governments, in partnership with hopefully all of you, private and public alike, in terms of health system strengthening, capacity building, as well as the development and delivery of the medicine. And we are committed to making our access principles operational in terms of making our products accessible to those who need it most. Happy to answer questions. And
thank you.
Didn't mean for the Novartis commercial.
Thank you very much. Yes. Thank you.
Good evening, I'm Salumi Mayer and I'm from the Cancer Alliance in South Africa. I think the issue that we really need to tackle, specifically when it comes to cancer, is that there's a lot of off-patented medicines that has been first-line treatments that are not available anymore. Not even from the originator companies, because why? They can't make money out of it anymore, or not even from the generic companies. That is starting to become a problem. So where are we then talking with regards to equitable access within universal health coverage? And I think it's going to be a very interesting model for city cancer
challenge, yeah.
as well as maybe from there to start seeing how can we actually bridge that specific gap in terms of providing what is really needed for low middle income countries. It's wonderful that in a high income country we have new drug developments. In terms of access program, the bottom line is, if you can give your product free, why don't you just lower your price? It's a basic concept. Why do you want to have an access strategy that is actually only there for selected few, but not really for everybody? And I mean, we have that challenge in South Africa with very specific access programs or access strategies, so-called, by pharmaceutical companies.
Okay, this is an open discussion, so please keep your comments very, very brief. Can I ask you just keep them to 45 seconds? Because we have quite a few. No, he had his hand up, and then we go over there, then I come back to the panel because Odama wants to comment. Here, then we take it that side.
I want to comment on what Stefan was saying. I can people sharing the high cost of treatment or this thing. It may sound very well in Europe or Western countries, but think of the continent where you said, well, it's only 1% of the economy. It means how much money you can really pull together. It's a big journey to go.
Yeah.
And in fact, I want to bring one instance where it was the market segmentation which worked very well. I think during the peak of the HIV epidemic, I come from India. I think there were condoms which were there. Same product, but packed in different ways, two different ways. the price of the nicely packed, this thing was almost 10 times more than the other one. And people choose themselves. And somebody earlier said also cross-subsidy. So this is also something which can really become, whether it's generic or segmentation, because end of the day, the companies also have to recover their costs, they have to have some profit. So you can't think of really reducing prices, and community sharing means the insurances, this thing. It's a far cry in the South Asia or the African continent, more than 45 cents.
Thank you very much. Please, just make sure I don't get fired by IFPMA, okay? We had his hand up for a long time. Then I'll come back to the panel because they want to comment on this issue.
Thank you very much. My name is Charles Gore. I'm from the Medicines Patent Pool. Okay. So I think one is to answer your question, I think generics are going to be extremely important because generic companies, by and large, their speciality is making drugs very cheap. They really understand how to produce more simply, better quality. So I think they're going to play a really important role, but the issue is, can we get generics into the market very close to the time that the originator products are in the market? In other words, when they're still under patent. And I think Novartis' program is great. We have a slightly different model that has worked extremely well in HIV, whereby originator companies give us a license for a specified territory, and then we sub-license it to generic manufacturers, but to a number of generic manufacturers, so that they compete amongst themselves. So rather than just having one, you might have 4 or 5 or 6, and that really drives the price down to a level that can fit into the UHC $40 per person, potentially. And if you look at the prices of ARVs across the world, this has really been dramatic, what it's done. And more recently, hepatitis C, where drugs that cost $150,000 at launch in the US, 3 years later, well under $100.
Okay.
That's competition in the market. So this won't work for everything, but it is a model, and it's entirely dependent on the originator companies being willing to do this.
Thank you very much. And please remember, this is not a pharma meeting. It is a private sector meeting, so I'd like to hear some views on other private sector, if there are any, but I'll get to you then back to the panel.
Thank you. Hi, my name is Natalie. I'm a member of UAM, which is Universities Allied with Essential Medicines. And I'd like to go back to the point that Stefan made. So you said, with the treatment that you had, firstly, it was very unaffordable, very high, and then it lowered, so it became more affordable, more cost effective. And that might be true on an individual level, but if we look on a bigger picture, overall prices are increasing. For example, you are from a Western European area, and if you look in the Netherlands, expenditure on expensive medicines is increasing 10% year upon year. So this is becoming an increasing problem as well, and that is something that needs to be looked at. And also, another thing is that between a third and a quarter of drugs, novel drugs, originate in academic labs, and that's publicly funded research.
May I react to that?
Good, thank you. So let me just come back to the panel here, with, Odame, and then I'll ask Stefan to comment back on that. Okay. Yes.
Right. So
You have your mic.
I think the conversation is getting kind of very interesting, and around the issue of affordability of medicines and how do we get the affordability clear. But clearly that tells us that health is very key in the SDG agenda. And just to quote what the Deputy Secretary General has been saying for a while now, that the SDG 3 is a docking station for all the other SDGs. Because clearly if we cannot assure affordability of medicines, then access becomes an issue. And then how do we get it going through? Just yesterday, I think the 0 draft of the political declaration came out.
Yeah.
And reading it through, I think it's increasingly clear that the issue of public-private partnerships is clear, because the 7th point was clear about it should be a paradigm shift. And I like that statement, a paradigm shift. But I always say that it can be nice rhetoric, but the devil is always in the details. And the 9th point talking about getting 1 billion more people getting access to medicines and all that. And then that's by 2023, and by 2030, another 2 billion people. That's still, to me, nice rhetoric still. How do we unpack that details? So I think going for one of the clear things that's increasingly is coming out clear that maybe we need to really unpack the cost of the private sector in coming out with some of these innovative medicines and what it really means in coming out with this cost. Because if we can unpack those costs very clear and see that these are the lines of cost, where can the public sector come in? So maybe R&D might be an area. If R&D is about 40% of the cost, and that's where the 42nd point in the Zero Declaration becomes important, where it's talking about public health-driven research and collaborating with the private sector in innovation, and also even looking at what they call development of innovative products and how the public sector comes in. Because I think that is very clear, and that's why I'm talking about the devil being in the details. Because if we're able to unpack those costs, and the public sector and private sector can then really have a conversation and see where the public sector can come in to alleviate some of those costs and how we're able to find the middle piece in there. Then I also want to end about the whole area of orphan medicines. But I think that's also a very big issue that sometimes we don't confront with. Because you can have a country like Hungary, 7 people with Fabry disease, and then one of those orphan drugs is about €500,000. Do those patients die? Do governments come in? How do we really look at all that? Because if we really are talking about universal health coverage, then it's all. And all means those on orphan medicines, those who have palliative conditions, those who have curative conditions, those who have rehabilitative care, those who have emergency care, those who have mental health. So the conversation needs to be broadened, and we can only broaden that conversation when we are really able to do some clear unpacking and have a conversation. Thank you.
Thank you. Thank you very much.
No, I just want to have a quick comment. I think healthcare is expensive, and health is expensive. And I think the most important challenge is to make sure that whatever money is put on the table is also used efficiently. And we see in Europe, and I'm sorry, I know only the figures for Europe, but we spend 1,500 billion euro every year on healthcare. That's a lot of money. That is really a lot of money. 300 billion of that money is wasted, according to WHO and OECD. 300 billion is wasted. That's 1.5 times the medicines budget, just to give you an idea. And of course, it overlaps a little bit with the medicines. What needs to be done is to make sure, together with the other stakeholders, that you understand where the efficiencies can be gained to make the system sustainable. And I think if you only look at one segment of it, then you're going to miss the efficiencies of the entire system. And I think it's very easy to say we're going to give less to pharmaceuticals or less to hospitals or less to this, that, and the other. No, you have to look at it from a patient perspective. Look at the inefficiencies throughout the system, what can be done. And very often there's a lot of reluctancy from a government perspective to engage in that kind of systems approach, because it's much more difficult to change how hospitals work, how doctors work, how doctors interact with hospitals, than to reduce the price of drugs, which is easy, yeah, in a way, or you don't allow the drug on the market. So I think we have to be very careful that we do not lose the ultimate outcome is to make sure that the limited means of the taxpayers is used in the most efficient way, with patient and health outcomes at the end.
At the end. Good. So don't look at pricing, look at the outcome and then work backwards. And this is what you're talking about, unpacking. So there is kind of...
is part of it, of course.
Exactly. So there's consensus here. So, Nelly, you want to say something about this?
Yes, and I do completely agree with the two gentlemen, because...
How boring. We're all agreeing. This is... Okay.
No, yeah, but...
No. That's right.
You see, the thing is, we have to also ask ourselves, this price, why is it high? Are there other factors beyond the cost of the drug, right? So he's addressed things like supply issues. I have seen the cost of a drug. I will use insulin, unfortunately, it's the area that I'm more familiar about. In Kenya, insulin, a vial was retailing for about $18, but when we streamlined the supply chain, it came up to about $4 to $5, right? Quite significant. And just because of the supply chain, we broke down, the middlemen and all that. So again, as we are also thinking about the issue, the cost of the drug, it's also important to look at other factors that would be leading to this cost. And this is where government comes in strongly. And I will keep being the voice of the government here, Dr. Adama, because we cannot wish government away. And they are the people responsible to deliver UHC to us. Therefore, it's through government initiative and support that we were able to tackle the supply chain issue. Then throwing another span in the works. I know we are still hanging. I'm still yet to be convinced about the generic and the brand. But then the other question is, would local manufacturing, I'm talking about the African continent here, would local manufacturing solve this? Would you, private sector, be ready to come and set up plants in Africa? Would that reduce the cost? Just throwing a spanner back in the works.
Okay, good. Susan, do you want to say anything on this issue?
I think the point about inefficiencies across the health system, and certainly in all the cities we work in, we see incredible amount of fragmentation across the health system, which is driving costs across the continuum of care. A cancer patient, once they're diagnosed, their treatment can last a lifetime. As apart from diagnosis, they're being treated, primary treatment, next treatment, palliative care, supportive care, and across all of those areas of care, you've got different health professionals, different technologies coming in. In Paraguay, we know that some of the health professionals spend more time in the car driving around Asuncion than they do actually in the hospitals, because they're moving between different centres because the care is so fragmented. So a patient might get chemotherapy in one place, but radiotherapy in another. In Colombia, a patient might have their first round of chemotherapy at one centre, but have their second round of chemotherapy, even on the same drug, in a second centre. And so how do we actually work with governments? Because that is all costing money. How do we work with governments to really help them understand that the continuum of care, and I want to just bring the word quality back into this discussion, because the UHC 2030 very clearly states that one of the biggest issues is access to quality care across the spectrum. And for this to be bigger than medicines, and I want to also bring in radiotherapy here. For cancer patients, more than 50% of cancer patients benefit from access to radiotherapy. So there's, I think, a bigger discussion about health systems and making sure that we all understand where are the trigger points to actually tweak the system to make it more efficient.
Fantastic. Now, I want a drink. I don't know about you, so I want to wrap up this. But I want each of the panelists to tell me just in 3 words, if you want to wake up on 22nd, 23rd of September and see the UHC declaration finally, what is that one thing you'll be looking for to say, this is my declaration because it has the following? So just, I don't want a long sentence, just summarize that. Do you want to start, Stefan?
3 words or 1 word?
3. I'll give you 3.
Solidarity.
Yeah.
Investments and organization.
Solidarity, investment, and organization.
Yes.
Good, thank you. Okay,
Design, no, I'm here. I was just looking at my good friends and getting his face for a while. Design. Design of systems, design of environments, and design of people.
Design. Good. Susan?
Put people first.
People, now you have to think again now.
She read my mind, right? Yeah, she read my mind. My first one was put people first, then leadership and quality.
Leadership and quality.
Yeah.
Ladies and gentlemen, please help me to thank this panel. Thank you. Thank you very much. Thank you. Great. Thank you to you all for that fascinating conversation. Thank you, Susan. Thank you. And we want a group photo, actually. I think this is, yes.
Okay. Go
yes.
back up.
Stefan. Don't go away. I'm going to invite Thomas Kweni to make some final closing remarks. There are no formalities here, so you can start as we take the photo so that we save people's time. Yeah.
And that's, of course, quite a challenge. But having listened to the debate, I must say from my side, I can only repeat what Fumi has already indicated at the beginning. From a pharmaceutical industry point of view, from the private sector point of view, we are passionate supporters of universal health coverage. And we are passionate supporters for universal health coverage because if we don't make progress, we will never reach the no one left behind. Having said that, since there was such a lot of consensus among the panel, I'd like to stimulate and give you a little bit of food for thought where I differ from some of the elements which were brought up. When I listen to Githinji saying Africa 1% of the global economy, when I listen to Rob Yates who said it has to be primarily public, I have to admit I'm not sure that we will make fast progress by trying to copy and paste the Keynes-Beveridge NHS model, because in economies where 50% plus of the economy is shadow economy, your tax revenue may be limited. Therefore, I do believe personally, and we were both at the panel this afternoon, hosted by the governments of Japan, Kenya, Georgia, and Thailand, I benefited from being born in Switzerland. Now, we introduced UHC in my country 32 years after the Japanese, and we have a different model from the UK, which did it in the late 40s. I do believe that we need to be open-minded and accept that one size fits all may not be the solution, and there are elements where if we really want to make progress on the triple billions, we have to be open-minded in how to achieve these goals. And I believe in the qualities of the NHS. I studied in the United Kingdom in London. I spent quite many of my years in Switzerland. I know France, I know Austria. All these systems are different, but by and large, no one is left behind. But if we want to make progress, we need basically universal health coverage. For me, it's mandatory. I was always thinking about my experience when I first went to Accra. You are one of the pioneers in Ghana in UHC. I thought you have about 50% coverage. I learned today it's more like 40, but basically it's the 40% who can't afford it. If you only cover the people who can't afford it and you don't get the insurance or the tax or whatever from those who can afford it, like me, if I were in Ghana, then you will struggle to finance. I'm always puzzled when I look at the Abuja Declaration 2001. I think as of now, there are about 3 countries meeting the objectives. Therefore, there's no way around mobilizing domestic resources, and we need to find ways and means to do that. But there's also no ways around. When I was at the Bio Congress in San Diego a couple of years ago, I met a professor of oncology from Nigeria, who of course doesn't practice in Nigeria, but in Chicago. But she said there's so many people in Nigeria who would love to pay for private healthcare if it were available, and there's a lot of potential. Therefore, I think we need to be not dogmatic, but open-minded to tap financial resources where it is. Maybe sales taxes, maybe insurance systems, maybe innovative funding mechanisms, and in many parts of Africa, we will continue to rely on development assistance. That's where Gavi and Global Fund made big progress. But I also want to end with a thought about where Githinji started. And of course, he provoked me, and Sue was far too diplomatic to give the response which I will give you about this fiction from Akanda, if I listened well. The minister should never be allowed to negotiate with the CEO on drug purchasing. The danger of corruption, the danger of misallocation of funds, the danger of inefficiencies is far too big. That's why, and Fumi Griego has spent quite some time and efforts in terms of how we as an industry can engage as private sector in this. You need the right systems, policy systems, which make sure that you have separation of power and you don't allow the minister to do shady business deals. Second, you need efficient procurement system. It's not just about, as Nelly said, the inefficiencies in supply chains, but it is, when I talked to one of our member companies a couple of years ago on a mental health program in a Central African country, they said, we basically had to go in and help how to build up procurement, how to make sure that we don't take them for a ride. Because if you do and cut corners short term, it will harm longer term. I believe in UHC for different reasons. If you have a UHC, I hope you will have a national formulary. And the national formulary should be about safe and effective medicines. It should be about a regulatory system. Nelly mentioned the question of local production. Now, local production, if you have 54 countries in the continent, I know every single one of them wants to have local production. I've been confronted with that kind. It may not be the most efficient way of procurement or getting, value for your money, which doesn't mean that it doesn't have a role. I listened to Charles Gore, and for instance, the medicines patent pool has really played a big role in the areas it's active. We are engaged in conversations whether the scope expansion could work in some, and I have to admit, it is important that we have a business model which is sustainable, which works, and we need to engage. I personally deeply believe in the importance of leaving out trenches, and I continuously challenge my friends from WHO that WHO is still far too much entrenched in, oh my God, private sector, that's dangerous, it's evil. That's why I really love Dr. Tedros' courage to leave the trenches and endorse partnership, but don't ask for, us being involved when it comes to rulemaking, when it comes to clear decision making, when it comes to procurement. You need clear guidance and avoidance of corruption. And we need to address the issue, for instance, of the money which is wasted and falsified to substandard medicines. But I do believe that we are on for a common journey. I love the booklet from Githinji in terms of the 6 asks. I would immediately sign on to every single one. And also to conclude with a note in terms of how the UN system can be innovative. I have to admit, I far prefer your magnetic umbrella to pins where I'm always afraid how to use them and apply them on my suits. Also, the umbrella reminded me 25 years ago, a journalist from a French-speaking newspaper here said, do you know how you're called here in Geneva? I said, no, of course, no clue. Monsieur Parapluie de l'Industrie. Mr. Umbrella of the industry, because all the shit which comes down on the industry, the criticism, you're the guy who needs to protect the industry from that. With these words, I wish all of you a nice evening, thank the great panel, our great moderator, and look forward to continuing our conversation. Thank you.